All right, everyone. I think we'll go ahead and get started with our next presentation. So we have Alex Arose and Jenny Tobin here for the next talk on multiple myeloma. So Alex Arose is a physician assistant and senior instructor in the Division of Hematology at the University of Colorado. Alex received his bachelor's degree in integrative physiology from the University of Colorado and his master's in medical science and physician assistant studies from Midwestern University. He has been involved in numerous program improvement initiatives in both malignant and general hematology, and recently accepted a position as the outpatient lead APP in the Division of Hematology. Jenny Tobin is a clinical pharmacist and the clinical pharmacy supervisor at UC Health for both inpatient oncology clinical pharmacy services and ambulatory malignant hematology and cell therapy clinical pharmacy services. She has served as the residency program director for the PGY2 Oncology Pharmacy Program at the Skaggs School of Pharmacy and University of Colorado Hospital. Jenny received her bachelor's degree in biochemistry and molecular biology from Trinity University and her doctorate degree in pharmacy from the University of Houston. Prior to becoming a supervisor, Jenny worked for 16 years as a clinical pharmacy specialist in the cell therapy clinic at Anschutz Medical Campus. Please welcome Jenny and Alex.
Right. Great. Thanks, Glenn, for that. It's my privilege to present multiple myeloma. This year, I have a team member in Jenny Tobin. It's great working with Jenny. I feel like our careers have taken similar trajectories and paths over the past decade or so. So it's really good to have a partner to kind of discuss what is a topic that is very near and dear to my heart, and that is multiple myeloma. So we do have a few learning objectives. Just briefly, we're going to be talking about multiple myeloma, the disease process, pathophysiology to some degree, and then we're going to really delve into both first-line treatments and then subsequent treatments in the treatment of multiple myeloma and review relevant medical literature and recent studies. And then we're also going to be talking about opportunities for collaboration between pharmacy and APPs in the optimization and treatment of these patients. So moving on, we have no disclosures. And we're going to start with a case study. As with any good medical lecture, it's always great to start with a case study to put this in real-world perspective. So we have a 73-year-old male with past medical history, significant for thyroid cancer and essential tremor, who presents to local ED with altermentation, arthralgias, and then on labs, he has some abnormalities of hypercalcemia, anemia, and AKI. And we can see that on the labs below. He actually has a pretty substantial anemia with a hemoglobin of 7.8. Calcium is quite elevated, greater than 15, and then serum creatinine is also elevated at 1.45. Some additional labs, his albumin is a little bit low, beta-2 microglobulin is a little bit high, and then his LDH is normal. So that's our case. We're going to take a quick break from our case to just start talking about multiple myeloma. Multiple myeloma is a malignancy of plasma cells, and with kind of the large majority of malignancies that we have identified, we don't really have a known primary cause of multiple myeloma. However, as with all malignancies, it generally starts with some form of genetic damage that causes a miscoding and a breakdown of normal clonal expansion of cells. So in this case, you get an abnormal clonal proliferation, and in multiple myeloma, it is of plasma cells. These plasma cells begin to propagate out of control, and they eventually cause the production of large amounts of non-functional immunoglobulin that really causes a cascade of negative implications for patients and end-stage organ dysfunction. So what are immunoglobulins? What are antibodies? What are we talking about here? So antibodies are glycoproteins consisting of both a heavy chain and a light chain. On this kind of cartoon up here, we can see a intact immunoglobulin. We have a Y heavy chain, and then we have light chains, which kind of attach to the wings. Together, these form an antigen binding site, which really helps the immune system function as it normally should. We also have a slight amount of free light chain that is produced in excess from plasma cells and just kind of floats around. And, this really is metabolized very well by the body in normal circumstances. The kidneys are able to clear this very, very rapidly. And they actually can clear in excess of free light chain, 20 to 60 times what the normal free light chain production is. Normal free light chain production is 0.5 to 1.0 grams in 24 hours, and they can clear up to 10 to 20 grams of free light chain in 24 hours in excess of this normal amount. So, our body is amazing, obviously, and it's really good at compensating for abnormalities up to a point. Unfortunately, these compensation mechanisms are eventually overwhelmed and cause a lot of problems. So, multiple myeloma. It is the end stage process or end stage result, I guess you could say, of a multi-step process of neoplastic transformation of plasma cells. It almost always starts as a monoclonal gammopathy of unknown significance. We get a monoclonal cellular population, and that cellular population slowly begins to grow. We get further genetic offenses or insults to the normal cell growth population. And then eventually we develop a more significant process of either a smoldering multiple myeloma or full-blown multiple myeloma. As these hyperproliferative plasma cells induce or undergo secondary genetic mutations, they continue to produce excessive levels of IgGs in the bloodstream, and this leads to a clinical manifestation of severe symptoms. To diagnose myeloma, I have the criteria up here. We have a 10% clonal plasma cell in the bone marrow, biopsy-proven bony lesion or plasmacytoma, and then one or more of SLIM or CRAB criteria, which we'll be going over on the next slide. So, we originally started with CRAB criteria. This is what we learn about in school. CRAB criteria stand for high calcium, renal dysfunction, anemia, and bone problems. If we think back to our case study, he had a few of these. He had renal dysfunction, he had high calcium, and then he had anemia, and question plus or minus whether or not he had bone problems, but we'll go over that in a second. More recently, we developed SLIM criteria. This was updated 8 or 9 years ago, and now we have the SLIM-CRAB criteria. SLIM stands for 60% plasma cells or greater in the bone marrow, light chain ratio greater than 100 or involved light chain greater than 100, and then MRI with one or more focal bone lesions. When we're working up multiple myeloma, we have to do a lot. Obviously, we're going to do a great H&P. We're going to get initial labs of just a CBC and a chem panel. And then we're also going to do a cardiac workup. We just had a great talk talking about the cardiac implications of treatment. And in multiple myeloma, we have kind of some subclassifications of this disease process, cardiac amyloid, that we need to rule out when we are working up multiple myeloma. So we're going to do a BMP, troponin. We can see on the right, we'll also be doing an echocardiogram under imaging. And then we also need to do a large battery of multiple myeloma panels that I'll be getting to on the next slide. In the middle here, we have bone marrow biopsy or tissue biopsy. This might be a bone marrow biopsy. We can also do a plasmacytoma biopsy. These biopsies are very, very important. I had an old preceptor in school who always used to say tissue is the issue, and that stuck with me for 15 years because without a tissue diagnosis, we don't really know what we're dealing with and we can't really start treatment. So for a bone marrow biopsy, we're doing morphology. What do these cells look like under a microscope? FISH, flow, next-gen sequencing to identify a clone. We also do a Congo rent stain to rule out the aforementioned amyloid, and then we can do a Ki-67 to see how rapidly these cells are actually dividing. So multiple myeloma panels, there's a bunch. This is kind of a busy slide. I will start with quantitative immunoglobulins. This is kind of how we determine how many IgG, IgA, or IgM immunoglobulins are actually circulating. From that point, we need to figure out if they are abnormal. So is there a monoclonal protein? So we go to protein electrophoresis, and we can do that on the serum and on the urine. And then immunofixation actually determines the type of protein in what we call an M spike, or a very high elevation. We also, as I talked about, need to evaluate for free light chain. So we will do a serum free light chain. And this will also determine whether or not the free light chain is kappa or lambda. Normally, we have an excess in kappa to lambda of about 2 to 1, but this can be quite variable in the setting of multiple myeloma. And then we do a 24-hour urine protein. This evaluates for renal damage. If there is an excess that the kidneys are no longer to compensate for, you get a spillage of protein that goes from the kidneys into the urine, and we can actually measure this amount in a 24-hour protein. These are just kind of cartoon depictions of what these assays look like. So we have quantitative immunoglobulins on the left. IgG in this is very, very elevated at 4860 when the upper limit of normal is 1295. So that's a very, very high elevation. And of that, the M protein, or the monoclonal protein, is 4.7. A quick note on this, IgG is very important for normal immune function. So some people will be like, well, why is this a problem? It just means your immune system's supercharged and ready to go. But that is not the case. These immunoglobulins that are monoclonal don't really work. So of that 4860 IgG, 4,700 of it is actually non-functional immunoglobulin. So this patient's actually very immunocompromised with a functional IgG of about 160. So that's why these things matter, as far as infections are concerned. We'll be going into infections a little bit later in our kind of collaboration aspect of this talk, but just something to think about. So additionally, we have immunofixation on the right. This assay kind of shows that there's a very dark band under the K, which is kappa, and then we can see underneath there quantified. Kappa is very, very elevated, 4,700, when the upper limit of normal is 19.4. So, these are just what we're looking at when we are trying to diagnose and figure out what's going on with multiple myeloma. As I promised earlier, talking about the case study, we will be talking about imaging. There are lots of options for imaging when we are working out multiple myeloma. The easiest, quickest, and cheapest to get is a skeletal X-ray, but a skeletal X-ray kind of sucks. Actually, it doesn't really show us a whole lot. And the reason why is there's a 30 to 60% trabecular bone loss before anything actually shows up on a skeletal X-ray. So by the time you're finding this on a skeletal X-ray, it's just not sensitive. By then, there's a lot of bone degradation and bone breakdown, and you're already kind of behind the curve, I guess you could say. Our first choice is an FDG Avid PET. That's what we like to do in most malignancies. It has the advantage of also showing how metabolically active lesions are. So that helps us determine whether or not they're progressing, whether or not we are getting response. So that's really our go-to. Whole body MRIs are also very useful in myeloma because they're very sensitive to bone issues. If there's a pathologic fracture, a breakdown, something along those lines. We can also do low-dose whole body CTs because sometimes they're easier to get and quicker to get than the MRI or the PET, but it's really kind of ancillary. We'd prefer to get a PET or a whole body MRI. So going back to our case study, this patient was admitted to the hospital for the aforementioned lab abnormalities, and he did get a PET scan, which showed diffuse osteopenia, and it had a mildly increased FDG avidity, suspicious for active myeloma. He got a bone marrow biopsy performed by our wonderful inpatient team, which showed 80 to 90% plasma cells. And unfortunately, he did have FISH cytogenetics that came back with a 1q21 gain, which is an unfavorable prognostic factor for multiple myeloma. In addition, he got a lot of these panels that we were talking about, and he was very highly elevated with kappa free light chain at 4,200, and then his ratio was elevated at 508. So what does this mean? I guess we have to kind of talk about how we stage multiple myeloma because that's really relevant into how we treat multiple myeloma. So we have several different staging systems that have been around for a while. The first is the ISS, or the International Staging System, that was developed way back in 2005, so about 20 years ago. And it is a pretty simple system. It really just evaluates serum albumin and beta-2 microglobulin on diagnosis and whether or not the serum albumin and beta-2 microglobulin are normal. If they are normal, you're stage 1. If their beta-2 microglobulin is elevated, you're stage 3. If you're neither of those things, you're stage 2. So pretty simple. We revised this in 2015, I believe, and incorporated LDH and some high-risk genetic factors. And then we further revised this in 2022 and incorporated a complicated points-based system, which I'm not going to get into, but it is another way for us to determine what stage or kind of how progressive their multiple myeloma is. This is important because on our curve here, we can see that as time goes on the y-axis, and the overall survival vertical axis, we can see that the lower stage myeloma does better, meaning that over time, their overall survival does not decrease as quickly as the higher stage multiple myeloma. So, this helps us determine how aggressive we need to be with treatment, whether or not we're going to need to, do an additional initial induction therapy and then go on to more of a consolidative regimen, or whether or not they can get maintenance therapy. So these things are important in how we treat our patients. In addition to staging, there's something called risk, and they are related but not the same thing. So high-risk multiple myeloma incorporates multiple factors in addition to stage, whether or not they are high stage or not. We incorporate further cytogenetic abnormalities into this. And then there's, the human piece or the clinical features. Are they advanced in age, the patient? Do they have extramedullary involvement, meaning do they have plasmacytomas popping up everywhere? Or do they present with plasma cell leukemia, which is a very aggressive and very bad form of this disease? So all of these things are relevant to what is high risk. At the bottom here, we'll kind of talk about primary refractory or rapid progression, which we consider functional high risk. And we'll delve into this a little bit more in our case study, but that's also something that we need to be aware of as we're moving forward in treating these patients. Going back to our case study, they were diagnosed with kappa free light chain multiple myeloma, and they were stage ISS3 or RISS2. So now we have our full picture, our full clinical picture. We have our disease, we have our stage. What do we do now? With this, I'm going to turn over to my partner, Jenny, who's going to discuss our initial therapies in multiple myeloma. And yeah, we'll take it away.
Thank you, Alex. All right, you guys ready to talk about some treatment, some trials? Yes, no, I see some nods. Great. You ready for lunch? Yes. All right, me too. All right, so before lunch, let's go through. So when thinking about newly diagnosed patients with multiple myeloma, we have to put them into two different categories: transplant-eligible and transplant-ineligible. Just to remind everyone, the type of transplant we're talking about here is autologous stem cell transplant. So we're going to talk about transplant-eligible patients first. So here we have all the trials looking at quad-based therapy. So quadruplet-based therapy for the initial treatment of multiple myeloma is the new standard go-to. So we'll be talking about quad therapy quite a bit here. Of note, you don't have to start with all four agents up front. As Alex mentioned, a lot of these patients present with renal insufficiency when they're first diagnosed. So there might be some agents you leave out and then you add in as the clinical picture changes and improves. Also, for anyone, the logistical concerns of getting lenalidomide or Revlimid started on a patient in the hospital, it can take some time. Of course, there's insurance issues associated there, which I'm more than happy to talk to anyone about. Fun part of our jobs, as always. But again, sometimes we add that in afterwards. So the two trials we're going to talk about today are the Griffin and the Perseus trial, looking at DARA-VRD. If I say DARA-RVD, it's the same thing as VRD. We call it RVD here, but the trial reported it as VRD, and so it's just trying to make my life difficult talking to you guys. But just know it's the same thing. And the only reason I'm going to talk about those two is those are the only two trials that have NCCN Category 1 approved indications. So the Griffin trial, again, this is looking at DARA-VRD. So this was the first trial evaluating quad-based therapy in newly diagnosed multiple myeloma in transplant-eligible patients in the US. So this was a phase 2 trial of about 200 patients randomized to DARA-VRD versus what at the time was standard VRD induction therapy for multiple myeloma. for 4 cycles, followed by an autologous stem cell transplant, consolidation, and then maintenance, as you can see depicted up there. What I would like to point out is that the daratumumab in this study was the IV formulation of daratumumab, which you don't see us using a whole lot, but we'll talk about. And the primary endpoint was stringent complete response after the consolidation phase. So what we see here in Griffin is that it was favorable in terms of the quad-based therapy. So adding daratumumab to our standard RVD backbone showed increased percentage of stringent complete response. It also showed, and this wasn't the primary endpoint, but it also showed increased MRD or measurable residual disease negativity. The other thing I'd like to point out is their primary endpoint was evaluated after consolidation. They also looked again at about 2 years after initiation of the trial, so a little bit longer than after that consolidation. And what you can see is that the stringent complete response rates and the MRD negativity both deepened with time. So not only are we getting good responses, but we're getting deep responses that increase with time. So now looking at Perseus. So Perseus is the follow-up phase 3 trial to Griffin. This was also mostly done in European countries, whereas Griffin was done in the US. Again, phase 3 trial, about 700 patients. The main difference here too is now we've switched over to our subcutaneous formulation of daratumumab, which is what we more commonly use now in clinical practice. Again, patients randomized to receive Dara VRD versus VRD triplet therapy alone for 4 cycles, autologous stem cell transplant, consolidation, then on to maintenance. They did split out the maintenance and the intervention arm, where if you achieved MRD negativity, you were able to drop the daratumumab and go down to lenalidomide therapy alone. Primary endpoint in the Perseus trial was progression-free survival. So Kaplan-Meier curves, we all love them, but here you can see once again, the quad-based therapy was favored over the standard of care triplet therapy. Progression-free survival, 84.3% in the quad group versus 67.7%, evaluated at 48 months. And this held true for all subsets of patients. So regardless of risk of disease, ECOG status, race, sex, any of the standard kind of subgroups, it held true for. So similarly to the Griffin trial, we also saw improvements in measurable residual disease with a statistically significant increase in MRD negativity in the quad-based arm when compared to triplet therapy. So in summary, for our transplant-eligible patients, we have improvements in progression-free survival with the addition of daratumumab to our standard VRD backbone. We also have higher rates of MRD negativity that are sustained over prolonged periods of time. No new safety signals were identified with the addition of daratumumab, which is always great, and we saw that consistent benefit across all groups. So this was pretty solid data, which led to the FDA approval of the daratumumab RVD regimen for transplant-eligible patients last summer, or I guess 2024, and also has an NCCN Category 1 recommendation. So this is going to be pretty standard therapy that you're going to see in patients. So what about our transplant-ineligible patients? Well, we want quad therapy for them too. So once again, quad therapy is going to be kind of our go-to. You don't have to start with all 4 agents up front. Oftentimes we aren't able to, just based on logistics, as I mentioned before, but you can start with 2 to 3 agents and add in as you go. I do want to also mention that for transplant-ineligible patients, there is also an NCCN Category 1 recommended treatment for frail patients. So these are going to be patients with poor performance status or greater than 80 years of age, and this is just Dara-RD. And this is based on the MAIA trial data. Not going to talk about it today, but just to mention there is a triplet-based therapy for our frail patients in the transplant-ineligible subgroup. The 2 trials I'm going to talk about today are Cepheus and IMROZ. And again, these are also trials that have that NCCN Category 1 recommendation, which is what we're going to stick with today. So IMROZ is looking at isatuximab. So isatuximab is also an anti-CD38 monoclonal antibody, similar to daratumumab, given a little bit differently. But IMROZ is now adding isatuximab to our standard VRD backbone. And this was a phase 3 trial of about 450 patients randomized to isatuximab VRD versus the standard VRD alone for 4 cycles, and then moved into a continuous phase of either ISA VRD or RD alone, so dropping that bortezomib. Primary endpoint of the IMROZ trial was progression-free survival. So we can see here on our Kaplan-Meier curve, once again, quad-based therapy was favored over the standard triplet therapy with progression-free survival 63.2% over 45.2%. So again, favoring that quad-based therapy. Looking again at the measurable residual disease, which are the orange and gray bars in the bottom, you can see that in the not only the intent to treat population, patients who had a complete response or patients who had sustained their response greater than 12 months, we see increased in MRD negativity with the quad-based therapy compared to the standard triplet therapy. So that was data with isatuximab. So now going back to daratumumab VRD. So this was the Cepheus trial, phase 3 of about 400 patients. Patients were randomized to either Dara RVD versus VRD alone, and then kind of moved to a continuous phase. This trial utilized the subcutaneous formulation of daratumumab, and the primary endpoint was looking at sustained MRD negativity rates at greater than 12 months. I'm sure you guys are shocked to see here, but the quad-based therapy was favored relative to the triplet-based therapy for both their primary endpoint. So 48.7% of patients sustained their MRD negativity at greater than 12 months when compared to the triplet-based therapy. Progression-free survival was also statistically significantly higher in the Dara VRD arm when compared to the triplet-based therapy. So in summary, similar to our transplant-eligible patients, our transplant-ineligible patients get deep responses. Not only are they deep responses, they sustain those responses and they have a longer progression-free survival. So the moral of the story is newly diagnosed multiple myeloma patients, we want to try to get them to that quad-based therapy, Dara RVD or isatuximab RVD, depending on if they're transplant-eligible or ineligible. And then again, remember, if they are frail or over 80 years of age, we also have that triplet therapy that we can fall back on. Back to you, Alex.
Yeah, Kaplan-Meier curves and MRD. That's what really gets everybody going before lunch. So yeah, thanks for that, Jenny. Going back to our case study, we did start this patient on a quad therapy of Dara VRD or Dara RVD, whichever way you prefer to say that. And, they initially did get a pretty good response. Their kappa-free light chain decreased to kind of a nadir of 16.35. And if you remember, it was almost 4,200. And their ratio dropped to 4671. So that we consider this a very good partial response with a 96% reduction in the kappa light chain. Just a quick note, the classification of response in multiple myeloma has like 12 different levels, and I didn't want to go into that today, but we would consider this a very good partial response. Unfortunately, pretty shortly after that, after a few months, the patient started to develop progressive disease after 5 cycles of this Dara VRD with increasing kappa-free light chain and ratio. So these are just kind of a picture of labs for the patient. So we can see on the right side, those are the older labs. They're very elevated kappa-free light chain and ratio to the point where you can't even see the whole number there at the bottom. And then they started on therapy and they did really well with a decrease down to 16.35, as I previously mentioned, for the kappa. And then the ratio went down to 46.71. But very shortly after that, unfortunately, they started to creep up again. Kappa went to 29 and then to 48. And then the ratio rose even quicker to 90 and 184. So shoot, what do we do now? I will throw this back over to Jenny very quickly. And this is kind of the most exciting part of this talk. So if you were sleeping before, this is the part to really wake up and get into it.
Okay. Relapse refractory disease. What do we do now? Y'all, the NCCN guidelines for relapse refractory disease for myeloma, there are a lot of options. All of it's going to depend on what you did initially and what patients are refractory to, what they responded to in the past, and the timing of it. So if you want to look at a really busy slide on NCCN, I didn't want to put it up here because it overwhelmed me looking at it, so I didn't want to do that to you guys. But there are a lot of options to choose for relapse refractory multiple myeloma. One thing I wanted to point out, just to mention here, some of our cellular-based therapies are CAR-T agents. They kind of come in the second-line setting. So Carvykti or cilta-cel is actually approved after one line of treatment. So our patient would actually be eligible for that if he was otherwise eligible for a CAR-T therapy. And then the other CAR-T product that we have isn't actually available for us to use until after 2 or 3 lines of prior therapy, but I just wanted to bring them up for completeness sake. But then I want to get into the exciting part. And I'm allowed to say this because I'm a pharmacist, but drugs are cool, right? And these drugs are really cool, some of them. So let's talk about some new stuff. All right. So when thinking about emerging therapies in multiple myeloma, I kind of put them into different kind of buckets in my head. So there's old drugs with new data. And the drug that really fits in there is belantamab mafodotin, which is an antibody drug conjugate, which is an antibody drug conjugate is the Trojan horse. So it binds to its target and sort of sneaks a toxin into the cell to kill it. So BCMA is B cell maturation agent, which is made on various cells in our body, but is also made on plasma cells. And so belantamab kind of sneaks the toxin in there. We'll talk about it a little bit more. New drug combinations. So some of our BCMA bispecific T-cell engaging agents, elrantamab and teclistamab, taking some of those agents that are approved in 4th-line therapy, combining them with some of our other agents and moving them up into lines of therapy. Some of that data is out there kind of cooking. New drug approvals. We had a new BCMA bispecific that was approved this past summer. This is Regeneron's dog in the fight, so to speak. There are 2 other, of course, BCMA bispecifics currently on the market. So now we've got a third. And then we've got the kind of coming soon drugs that are currently being evaluated in trials. So in terms of other BCMA bispecifics, there's many that are in the pipeline. Cevostamab is one that we'll talk about kind of briefly, but this is a different target bispecific, which is really cool, and I'll tell you why, I promise. If bispecifics are good, why not trispecifics? So this is a really exciting one that was presented at ASH last year, the phase 1 data, and it was presented again at ASCO. And this one's really exciting. And again, I promise I'll tell you why I will not withhold the exciting information. And then CELMoDs, so these are oral agents. These are like pomalidomide and lenalidomide 2.0s is kind of how I think of them. And there's 2 in that class. And so let's kind of start rocking and rolling through these drugs. So belantamab mafodotin, I already told you a little bit about how it works. It's an antibody drug conjugate. So mafodotin is the toxic payload that gets delivered when belantamab binds to BCMA on the outside of the plasma cells. And mafodotin is a microtubule disruptor. So that's how it has its anti-cancer effects. So this drug was approved in August of 2020. Great time to take a drug to market. Nothing was going on in the world. But it was originally, it had accelerated approval. So for those of you not familiar with how the FDA works, some drugs are given this accelerated approval and companies are allowed to take them to market with phase 2 data, and then they have to come back with confirmatory phase 3 data to get the full FDA approval. So that's kind of the situation belantamab was in. So actually what happened is then 3 years later in November of 2023, belantamab was withdrawn from the market because their confirmatory phase 3 data did not match with their phase 2 data. So their progression-free survival wasn't looking good. Now, this was with belantamab used in monotherapy. So we'll talk about why I think it's going to make a comeback here. You might also remember this drug because it had a very unique side effect profile. There was a REMS program for ocular toxicity, specifically for keratitis. And so this is where we had to send our patients to the eye doctor prior to every dose to get the okay to treat. So you might remember having to deal with that. So it didn't really pan out in monotherapy. What about in combination therapy? So there are some ongoing phase 3 trials looking at belantamab mafodotin in combination with other agents. So the DREAM-7 trial is a phase 3 trial looking at belantamab, Velcade, dexamethasone versus Dara Velcade dex in patients with relapse refractory multiple myeloma who have progressed after one line of therapy. So again, thinking back to our patient case, our patient would have been eligible for this trial. The primary endpoint was median progression-free survival, which was higher in the belantamab arm than compared to the Dara Velcade dex arm. Grade 3 adverse events were higher in the belantamab arm, but the majority of those were attributed to those ocular side effects that I already told you about. DREAM-8, this is another phase 3 trial. This is now switching out the, doing a pomalidomide-based triplet, so belantamab, pomalidomide dex versus pomalidomide Velcade dex. And these are in patients who were lenalidomide exposed after at least one line of therapy. Again, you can see the primary endpoint of median PFS was improved in the belantamab arm over the comparator arm. And once again, grade 3 adverse effects were higher in the belantamab arm. Again, most of that was attributed to the ocular side effects. So belantamab, maybe making a comeback. Okay. Linvoseltamab. So as I said before, this is the Regeneron dog in the fight. So this is a BCMA bispecific T-cell engaging agent. The other two approved drugs on the market are teclistamab and elranatamab, if you're familiar with those. This is approved in relapse refractory multiple myeloma after 4 prior lines of therapy. So as is typical for our BCMA bispecifics, there is a step-up dosing schedule. All of the step-up dosing schedules are a little bit different. What I like about the step-up dosing schedule with linvoseltamab is that it's done on a weekly basis, which makes it a little bit easier, I think, logistically to kind of plan out. And the max dose is 200 milligrams, which you continue subcutaneously for 10 treatment doses, and then you kind of decrease as you go further out. The approval for linvoseltamab was from the Linker MM1 trial, which was a phase 1/2 trial. For completeness sake, I put up the 2 doses. Phase 1 trials are where you're looking for the dose and toxicity. We're not really going for efficacy quite yet. Sometimes when you have these phase 1/2 trials, you have different doses that are included. So the FDA approved dose is the 200 milligram dose. So that's the one I want you to focus on, but it felt like I was leaving stuff out if I didn't put the 50 up there. So for these patients, the primary endpoint was looking at overall response rate, which was higher than the comparator arm. Again, it's a BCMA bispecific. You're going to see things like CRS or cytokine release syndrome or immune effector cell associated neurotoxicity. So those are things we want to think about. For CRS, the majority of the reported cases were grade 1 or grade 2, with a very small percentage being grade 3. ICANS was a little bit spread out between grade 1, 2, and 3, but overall fairly low. And then in terms of other side effects, neutropenia, anemia, infections, things that we would anticipate to see with the BCMA bispecifics. Okay, so cevostamab is really cool. So this is why it's really cool. So it's also a bispecific, similar to linvoseltamab that I just talked about. However, it has a completely different target. So it's not BCMA, it's this FC receptor homolog 5, which is different because it's almost uniquely expressed on plasma cells only, whereas BCMA is expressed on other different types of cells, and you get these off-target effects. Cevostamab, you're not going to see that near as much because its target is almost completely on those multiple myeloma cells. It's currently in a lot of different trials, both monotherapy and combination therapy. The one that I wanted to point out was the KAMA-2 trial, which is an ongoing phase 1/2 trial. And the reason I think this trial is cool and will offer some really good information for taking care of these patients is they allowed patients who had progressed after anti-BCMA therapy, which is where I think cevostamab might have a big role in the treatment of multiple myeloma. Some of the kind of initial overall response rates coming out from that trial. So in patients who had received a prior BCMA CAR, 73% had an overall response rate. And if they had any prior BCMA therapy, which can include a bispecific, their overall response rate was 67%. So that's a pretty heavily treated patient population and to get those high overall response rates. That's something that I think is pretty cool. It also does have a step-up dosing, as all of our bispecifics are going to do, and they do require that patients are admitted to the hospital to manage that initial CRS. Okay, here's the trispecific. This one's really cool. I mean, I think all drugs are cool, but you know what I mean? This one's different. Okay, so this one's different in that it has 3 different targets that it binds to on the myeloma cells. So there's the CD3 component, which brings the T cell in proximity. So all of our tri or bispecifics are going to have some sort of T cell engaging component. But then it also has a component for BCMA and CD38. So now we've got 2 different targets on the myeloma cell. And the thing that's really cool, and I can't do my scientific colleagues justice here and how they built this molecule. But one of the ways that people develop resistance to BCMA therapies is the plasma cell just quits making BCMA. If the plasma cell doesn't make BCMA, you can't target it. The way that this trispecific drug interacts with the plasma cell, it makes it really hard for the plasma cell to quit making BCMA. So it kind of gets rid of that mechanism of resistance, which I think is pretty cool. So again, this drug is so new, it doesn't have a name yet. We're still with letters and numbers. So really the only data that's out right now is the phase 1 dose escalation study. So we don't even really have a set dose quite yet. Patients with prior BCMA therapy or T cell directed therapy were allowed. It has step-up dosing, similar to what we'd expect with a bispecific. Again, this was a pretty heavily pretreated patient population where we saw, overall, we're seeing some pretty good responses with this drug. It's one that I know that our physician group is really excited about. So overall response rate of 75%, and that's across all dose levels. So in a phase 1 trial, you don't even know what the best dose is yet. So you might be giving a suboptimal dose and we're still getting overall response rates of 75%. So I think that's really great. Trade-off, we get about 70% incidence of CRS or cytokine release syndrome. Again, the overwhelming majority of cases are grade 1, grade 2. We can deal with that. That's no big deal, with a median onset of 3 days and only lasting 2 days. So really cool drug. I think we're probably a couple years from seeing this really hit the marketplace. But again, something to keep an eye out for. Really, really exciting. Last thing we're going to talk about is our cell mods. These are what I described earlier as pomalidomide and lenalidomide 2.0. So this is a new class of immunomodulatory agents. These are oral agents. They're more potent than traditional immunomodulatory agents. They do a really good job of enhancing proteasome-mediated protein degradation, and they also enhance the immune system by activating T cells, cytokines, and the great thing, I think, where these cell mods are going to have their niche in therapy is you can use them in patients who have progressed or are refractory to our standard IMiDs. So patients that are now considered resistant or refractory to pomalidomide or lenalidomide. Also, we don't really know what this means clinically yet, but we know that these cell mods can increase the expression of CD38. So maybe that might restore sensitivity to our anti-CD38s or make them more sensitive, the myeloma cell more sensitive to them as a potential. So there's 2 drugs in this class that are currently being studied. So mezigdomide is actually the newer one, which I'm going to talk about first. It is used in relapse refractory myeloma. And again, they're using it right now in monotherapy. So the phase 1 trial, again, a dose escalation study, the overall response rate at 6 months was 25%, which doesn't seem all that impressive with some of the other overall response rates I've given you. But remember, this is just a drug and dexamethasone in combination. And we don't often use immunomodulatory agents as monotherapy in very many cases, maybe for smoldering myeloma, maybe in a maintenance phase, but never for a treatment. It's always going to be in combination with something else. Toxicity profile, again, very things that you would think of for immunomodulatory agents, cytopenias, nausea, fatigue, very much class-like effects. Phase 2, we found our dose. You see mezigdomide 1 milligram in combination with dexamethasone. The overall response rate, again, now that we have our dose picked, you see it goes up to about 41%. This is relatively comparable when you look at pomalidomide dex or lenalidomide dex in some of those older studies. The overall response rate in those patient populations is about 30 to 40%. And again, we saw actually higher progression-free survival if they had received a prior BCMA therapy. So iberdomide, so this one is a little bit more kind of through the development pathway. There are actually ongoing phase 3 trials with this drug in combination. But just to be clean, I only presented here the phase 1 and the phase 2 data. So again, looking at this drug in combination with dexamethasone, again, the overall response rates we see kind of in that 20 to 30. Again, this is using it in monotherapy with just dexamethasone. Toxicity, very similar to what we saw with mezigdomide, very similar. Most common AEs were neutropenia, anemia, infection, and thrombocytopenia. So again, where do I see these drugs being used? I see these drugs being used in combination therapies once we have that data to support their use. And I see them being used in patients who potentially develop resistance or refractoriness to our current IMiDs on the market. So I know I blew through a lot of new drugs really fast, but here's my summary. Chemo is out and immuno-based therapy is in. So we're going to move our bispecifics and CAR-T. We're going to move those to earlier lines in therapy, and we're going to start varying treatment. So we're going to start mixing and matching some of those bispecifics with other agents. Belantamab, this is its year for a comeback, maybe. Again, not in monotherapy, probably in combination. So watch for that comeback. New targets for bispecifics. So cevostamab. So remember, cevostamab has that FcRH5 target, which is almost exclusively produced on myeloma cells. So you get less off-target effects. So that's great. And that data in the KAMA2 trial, this might be really good for patients who have progressed after BCMA therapy. We've got new BCMA bispecifics coming out, linvoseltamab. I'm sure we're going to see more. And we'll just have to watch to see if there's any data to suggest which one might be better than another. Bispecifics are great, so now trispecifics, why not? And again, this trispecific that is coming currently in phase 2 trials now is it helps prevent resistance by kind of that unique molecular configuration. And then the immunomodulators 2.0. For our patients who might develop refractoriness to our current IMiDs. You're almost to lunch, guys. Almost there.
All right. So I know everybody's waiting with bated breath as to what happens to our case study. But before we go there, we really wanted to steer into a little bit of APP and PharmD collaboration, as that is the theme of the topic. We have lots of areas in which we collaborate in the management of multiple myeloma with our pharmacy colleagues. This next 2 slides are kind of a graph outlining a few of those. The top 2, I'm not actually going to go into at all right now because I'm going to delve into them a little bit more deeply in subsequent slides. So we'll just kind of move down to infections. So as I mentioned before, these patients are really prone to infections. They're immunocompromised for a number of different reasons. So, sometimes we're treating active infections. Oftentimes we are prophylaxing. Recently, we've been prophylaxing our patients with Levaquin for 12 weeks after initial diagnosis, just to try and kind of prevent any infections during their initial induction therapy. And sometimes we have to do prophylaxis for PJP. We do prophylaxis for shingles. So always something that we're kind of looking out for. We also have to do immunoglobulin replacement. As I said, these patients have a deficiency of functional immunoglobulin, so we have to give them immunoglobulin so their immune system has the tools it needs to work properly. And then vaccination. A lot of these patients end up getting intensive therapies that require them to be revaccinated, in addition to the yearly seasonal vaccines that we all love to field questions on every year around this time. So lots of things that we are dealing with, and there's a lot of collaboration and discussion between pharmacy and APP on how we need to handle things. In addition to being a prothrombotic state in itself, because it is a malignancy, a lot of the medications we give patients to treat plasma cell disorders can also predispose them to acquiring clots or put them in a hypercoagulable state. The greatest example of this is lenalidomide or pomalidomide. And in these situations, we have to prophylax it at minimum with aspirin, and then if they do actually have a clot, we often give them a DOAC or direct oral anticoagulant or low molecular weight heparin. These medications need to be renally adjusted, renally dosed, and sometimes we are engaging our pharmacy colleagues to help out in doing so. And then renal dysfunction. We've kind of discussed quite a bit how renal dysfunction is a hallmark of multiple myeloma, and almost all of the drugs that I'm starting on a multiple myeloma patient, I'm checking renal function. And if I have any questions, I'm going to Jenny and saying, hey, does this need to be dose adjusted? Does this need to be dose reduced? Is this something that I can even give this patient? So these are all things that we have to be concerned about and collaborating on when we're treating these patients to not cause more harm than good. Delving a little bit more deeply into a couple of these that were on that previous chart. So hypercalcemia, talked about it with Crab criteria. Our case study came in with hypercalcemia. It's not a fun condition to be in. It's caused primarily in the setting of multiple myeloma by local osteolytic hypercalcemia development, meaning, your plasma cells are breaking down bone and they're spilling calcium into the system. Symptoms of this, there's a lot. You can get muscle weakness, generalized weakness, but you can also have more kind of smooth muscle focal hypoactivity causing constipation. If you remember, this patient presented with confusion to the ER. Altered mental status is a hallmark of hypercalcemia, and calcium was quite high at 15.2. Prolonged hypercalcemia can cause kidney stones, renal failure, cardiac complications, lots of different things that can happen with hypercalcemia. So how do we manage this? It's variable based on how severe it is. And this is another area in which we are definitely engaging our pharmacy colleagues. If we are dealing with a mild hypercalcemia less than 12 and the patient is asymptomatic, we might not be doing anything other than treating the underlying cause of the main problem, and that is their multiple myeloma. So, we really just need to get their myeloma under control so it stops this process. If they have more moderate hypercalcemia, 12 to 14 range on serum evaluation, we consider treatment. We can give hydration, and then we might start with a bisphosphonate therapy that functions by kind of pulling calcium back into the bones and getting the osteoblast activity increased. I always get clasts and blasts mixed up in my brain. But bisphosphonates are kind of a hallmark of management in multiple myeloma. And in this case, typically it takes a few days for this to engage, and we need to watch for complications, which I'll go over in a second here. Additionally, severe hypercalcemia, we might give a bisphosphonate, but it's not going to work immediately. So we might be doing aggressive hydration. We might do calcitonin. In really severe cases, if they're admitted inpatient, we might need to do hemodialysis to kind of get their kidneys at least protected to some degree, or at least recovering to some degree to make sure that we're not getting behind the ball too much. And then sometimes we can give steroids as well for this. So the next complication that we need to be aware of and that we often engage our pharmacy colleagues with is bone disease. So most often when you think about bone disease in the setting of plasma cell disorders and multiple myeloma, it's like a big T10 lesion that's compressed, that's causing a lot of neurologic issues. And that's what we're kind of talking about on this slide. This management is really emergent. Patients are often admitted to the hospital. They're getting steroid right away to just calm down any inflammation and try and salvage whatever neurologic function we can. And then they're getting radiation therapy, local radiation therapy. These tumors are very radiosensitive, so we try to get our radiation colleagues consulted very quickly to try and get this under control. When we're engaging our pharmacy colleagues more frequently is in the setting of prophylaxis. We start all of our patients on initial diagnosis on a bisphosphonate therapy and typically continue it for 2 years. We have to worry about complications when we're doing this, so this can cause hypocalcemia. Interestingly enough, in clinic yesterday, I had to talk to Jenny about this, which we thought was very time prescient. This is something that we have to be aware of. These bisphosphonates, they take a while to work and they have a long half-life, long mechanism of action. So hypocalcemia is something that can develop because they keep working for a long time. They also have to be renally dosed or renally adjusted. So that's sometimes that we're engaging pharmacy about that. Lots of opportunity and need for collaboration between our two groups to make sure we're doing things correctly and safely. So going back to our case study, our patient was salvaged, I guess you could say, when they started to relapse with DARA KRD as a second-line therapy, so a different quad therapy. And they got a pretty good response out of that. Their kappa free light chain decreased from 47.84 to 9.2. You can see that on this line right here. Then ultimately they underwent treatment with cilta-cel or an anti-BCMA CAR T-cell therapy. They did get some CRS with this, were admitted to the hospital for a little bit longer than sometimes we like to see, but overall did really well. And they actually got a great response, which I did not put a little line there to highlight, but as you can see, the kappa-free light chain actually completely responded and is no longer detectable. To wrap things up, I just kind of wanted to highlight the major thing I think is important to take away from this, and that's in Jenny's kind of second set of slides there, is that management of multiple myeloma is changing very rapidly and in new, exciting, good ways. I started my career about 12 years ago, and we didn't even have daratumumab then, and daratumumab I thought was a game changer when that kind of came out. And then over the next decade, we've just acquired more and more agents for which we can treat multiple myeloma. It's still thought to be an incurable disease, but lots of things in the history of humanity were thought to be incurable until we cured them. So I think the future is very bright. We have a lot of opportunity to continue to help patients, and maybe one day we will cure multiple myeloma. Who knows? So. Yeah, let's stand together.
Does anybody have any questions in the room here? If not, I won't hold you back from lunch, and thank you guys for this talk. I think the pharmacy, APP provider, nursing collaboration is one of the most important parts of the care we provide our patients. So very, very good talk. Thank you very much.